Welcome to our webinar featuring employer-sponsored primary care health centers, enhancing access, patient experience, quality, and cost savings. My name is Mark Levine. I am the Deputy Director of your New York State Association of Counties. Our topic today will discuss how employers continue to be challenged with increases in healthcare costs, lack of access to primary and mental health care providers, and employee recruitment and retention concerns. Today's webinar will focus on an innovative strategy self-funded employers like counties are implementing across the country to directly impact these challenges and produce better overall health outcomes for their employees and populations. We've had Marathon come and speak to a number of our conferences and meetings at conferences over the course of the last year, and really it's an interesting concept, and counties across the state are very intrigued by this. I think you will find the same, and if you have questions, we encourage you to ask them by submitting them into your questions or chat panel, and we will ask our speakers at the end of their presentation. Before we begin their presentation, I want to turn it over to Jeanette Stanziano for a few brief housekeeping announcements. Jeanette is our Director of Education and Training, and she's coordinating today's webinar. Jeanette.
Thank you, Mark. As Mark mentioned, we are recording this program as we do with all of our webinars. We will be posting the recording and a PDF of the slide deck on the NYSEC website at nysec.org. You can also find the recording on our YouTube channel, NYSEC TV. These two items will be posted about an hour after we conclude today's webinar. As Mark said, we want to encourage everybody who is observing the webinar today to feel free at any time during the presentation to submit questions for our speakers. The way that we ask you to do that is to please refer to the Questions tab on your dashboard. Simply click on the Questions tab, type in your question, and Mark will moderate a Q&A at the conclusion of the presentations. Back to you, Mark.
Thanks, Jeanette. And we want to thank our speakers today. They're experts in the field, and they have an innovative message, and we're pleased that they're going to share that with us today. Mark Schubert serves as the Vice President of Sales for Marathon Health, where he leads Marathon's growth by partnering with commercial and public sector employees across the Northeast. Mark has spent his entire career partnering with employers to design, implement, and execute outcomes-focused health and well-being strategies. He received his undergraduate degree from Towson University in sociology. And our second speaker is Chad Ashcroft, who serves as the Chief Growth Officer for Marathon Health, where he is responsible for driving new sales and channel expansion. Chad joined the company in 2013 and has held product, innovation, and sales leadership roles. Chad has more than 20 years of experience in enterprise sales, business consulting, strategic partnership, and developing new go-to-market strategies for high-growth companies. He received his undergraduate degree from DePauw University in computer science and a master's degree in information and communication science from Ball State University. Thank you, and it's my pleasure at this time to turn it over to our first speaker, Mark Schubert. Mark.
Thank you so much for the warm welcome there, Mark. Appreciate the opportunity to be here with you all today. As Mark had mentioned, we started our partnership with NYSEC a little over a year ago and had the pleasure of attending the fall conference last year and getting some visibility with county executives across the state. Since then, we've spent the past year engaging with various employers on the topic of employer-sponsored advanced primary care. I want to be able to share with you all today some more information about health centers as a strategy and really the value they can create for employers, but also the employees and the family members. So in our time together here today, we're going to highlight some of the critical challenges facing employers, things that will hopefully resonate with you all as an audience, but then some of the specific steps you all can take to explore employer-sponsored primary care. So we'll provide an overview of what it is, how it works, the patient experience it creates, and then the value and outcomes specifically for employers that can be achieved with this model. Go ahead and advance here. So as you all go about your days and focus on your strategies and how you take care of your employees and their family members, a variety of challenges have confronted employers across the country. And so, Chad and I work across the country, and it doesn't really matter where we go, the challenges exist. And specifically in New York State, we know that these challenges exist. So first and foremost, a lack of access to primary and mental health care. For those of you who have tried to find a new primary care, it can become very difficult, the time to wait to get an appointment, who's actually taking care. There's this whole concierge medicine that a lot of providers are going into. A lot of primary care providers have retired, and there's not enough to replace them. And then you think about how hard it can be to get a primary care appointment. It can be equally or more difficult to find mental health care, providers not taking insurance, self-pay only, and just the lack of access that it can create becomes a real problem for the health of a population. And similarly, there are areas we see that have a lack of access to care. We also see areas that have 1 to 2 dominant health systems in the region where prices just continue to get driven up, and up. And that's what leads to these health insurance increases of 6 to 8%. So for those self-funded employers on the call, your experience over the last 5, 6 years, what types of increases are you getting? How are you sustaining them? We've done a lot of different things with co-pays and deductibles. We've pulled different levers, but what is a longer term strategy to really combat the rise of those of your health insurance costs? Attraction and retention. It's a very real challenge. There's a limited labor market pool. It can be a tight labor market pool. How are you all thinking about how do we attract and retain, and how do we use benefits as a strategy to do that? We're going to talk about how health centers can really drive attraction and retention, create a great benefit. I'm sure you all have heard or are having the conversations about RX costs, drug costs. We've got these new anti-obesity GLP-1 drugs. How are they being used by your population? And a lot of employers worry about paying for all these drugs, but are people really living a healthier lifestyle? Are they taking it for vanity reasons, etc.? Health centers can be a great way to kind of be an arbiter of those drugs, work with providers, have more oversight over how those are administered and the successes that they can create for people. We have a lot of talk in our society right now about price transparency. There's the whole Consolidated Appropriations Act, more so putting a fiduciary duty on employers to be aware of what their spend are, how much they're spending on insurance, how much their folks are paying for certain procedures, etc. And then lastly, and I came from doing human resources and benefits in a firm. And one of our top challenges was we've bought and got all these great solutions for our employees, but we get very low engagement and utilization of all these great benefits. How could we create more of a hub for all of the great benefits we offer so that when folks need them, they know where to come and get them? And so all of these challenges that are laid out for employers, they all result in things: low quality outcomes, bad experience for the plan sponsors and patients, and then of course for you all as employers, ever increasing health spend. I also think it's important to consider it from just a patient consumer standpoint, right? What is it like to try to get and access quality healthcare in our country? And I found this Harris poll through Time from last year, 2023. But if you look at some of the key barriers folks put forward in terms of accessing healthcare, affordability. You know, people, those co-pays, the premiums, it's become very expensive for everyone. So what can we do about that? Access, you know, through insurance coverage or just physical access, understanding what's covered, lack of primary health care providers, which we've already discussed, depersonalization. You feel like you're just being churned in and out. You get a 10 or 12-minute appointment with a primary care provider, and then you're on your way. And so all of these things, between both what employers are facing and then, you know, employees or patients are facing, we think that there's a better way to provide care to both the patients as well as the employers. And so we think about this concept of advanced primary care, direct primary care, you've heard it, clinics. We are reimagining healthcare and essentially how it is experienced, delivered to and experienced by patients, and how it can be purchased by employers. Very focused on creating convenient access. So when you hear something like advanced primary care, one of the components of that are multiple access points. So not just coming to a brick and mortar doctor's office, also having access to virtual care. So reducing any barrier to actually get that care, reduce cost barriers through these health centers. You can provide free or low cost care. And because it's not an insurance product and you have, you know, thousands and thousands of people accessing it, it's sponsored by a single employer, that means longer appointment times and more meaningful engagement with the providers. We also want to put a focus on independence. You know, when you have these more and more of these primary care providers are tied to health systems, and wouldn't you know, they have quotas for getting referrals, et cetera, up into the health system. You know, it's important in this type of arrangement, employer-sponsored care, there are no you know, financial ties or reimbursements to insurance carriers, hospitals, or specialty groups. And so the focus is very specifically on the patient and the best course of care for them. And so that all comes with, you know, advanced primary care, where we can offer primary care, urgent care, mental health, occupational health, all in one convenient setting for a member. So if you look at kind of a traditional fee-for-service, you know, what we've all known as, you know, you go in, you can wait quite a bit of time in that waiting room. It's typically a 10 to 12-minute appointment. This says up to 16. I don't know about you all, but my appointments prior to moving to this model are about 10 to 12 minutes. You know, you got your referrals. If you needed labs or drugs, you got sent on your way. Within this model of advanced primary care, you're typically spending around a half hour with your provider. You have access 24/7. It's about getting same day, next day access to care, which all leads to a better patient experience. And then, of course, you know, the out-of-pocket costs, as Chad will talk about, you know, in these programs, they're value-based per member per month, sponsored by the employer. In many cases, there are no costs to the patients, which are the employees, as they access these centers. And so if you take a broader look at it and, you know, map kind of what does this look like, this visual is meant to represent, you know, at a very high level of how this works. And so before I turn it over to Chad, essentially the way the model works is you take an eligible population, again, that's part of an employer. Primarily self-funded employers use this model because of the cost savings that are able to be demonstrated. But the employer chooses the eligible population, whether that's the employees, all employees, whether they're on the health plan or not, spouses and dependents on the health plan, retirees. The employer determines who will have access. There are a variety of access modes, which Chad will talk about. Whether it's on-site, you know, literally a health center on-site of one of your premises, or a near-site, more so out in a retail setting in the community, plus the virtual. We're taking the providers will take advanced data, intake claims, medical and RX, run that through risk stratification so we can do population health. We can provide a whole multitude of primary care, urgent care, labs, dispensing of generic drugs, so comprehensive care right in the health center, social determinants of health, making sure we reduce other barriers to care like transportation, financial services, etc. And then we're able to drive out into the larger ecosystem of benefits that the county may have available, including in-network providers. As you'll hear from Chad, this sits alongside of your health plan, so we still will have to make referrals, but pharmacy benefits, point solutions, so mental health, EAPs, all those types of things we're able to help drive folks through the kind of hub of the health center. And so all that to say, we've made a lot of progress with health centers. I think I may have skipped a slide earlier, but we see a lot of this model with public sector employers, including counties, because of the ability to drive down total cost of care, create a valuable benefit at no cost to the employees, centralize and optimize all of your health and well-being resources, and then create a really attractive benefit that keeps folks there and employed with you all, as well as attract other folks as well. So I'll turn it over to Chad now. Chad's going to talk a little bit more about the model itself,
sure,
the features of it, and then specifically how it creates value for the employer. Chad?
Yeah, thanks, Mark. Yeah, so Mark really went through a lot of what some of the problems are that we're all experiencing within member engagement and rising cost of healthcare on your self-funded plans, especially, or also in fully insured programs as well for employers across the board, no matter what industry, but in particular for public sector groups that we've worked with and seen this become a really big driving need. The equation's kind of simple when you look at the value chain and kind of getting to what we do. But it's the same for any wellness benefit you put in place or health benefit you put in place, which is give people access to really high quality care, driven by services, patient services, whatever, digital, in person, etc. Give them a good experience so they want to keep coming back and tell their friends and get their families involved. And then have that group or have that vendor, as long as they're focusing on really driving outcomes, right? And that's the key piece that Mark kind of touched on earlier around, in a fee-for-service world with traditional fee structure, primary care, acute care, et cetera, there's not really an incentive to drive outcomes. It's really kind of treating more of a symptom or a problem set. But in our case, with what we do and other vendors in the space would do for our employer groups who we partner with, really focused on driving population health outcomes and taking accountability with that, which is that value-based care kind of model and fee structure that we all kind of put in place. So you do those first three, give them good access, give them a good experience to want to keep coming back and repeat utilization, really focus on targeted outcomes. That's when you get the fourth kind of leg of that stool, which is where you see those costs of care shift downwards and lower, and the savings really materialize for you, both your employees and households that are members of your plan out of their pockets each and every month because they're healthier and because they're spending less in the open market, but also the health plan, right? As a whole, trend rates tend to reduce by 3 to 5% on your medical benefits annually. When you look at that, we know that engaged members who are really engaged with this kind of service tend to spend about 20 to 30% less per year than members that aren't engaged. By contrast, just looking at your own benefits plans today, you can probably see in there, talking with your benefit consultants and your actuary teams, to see that people that aren't engaged, disengaged members with the health system cost the plan 4 times as much. They have out of control gaps in care and compliance with chronic conditions, things like that. And they're just not spending their own money wisely. And sometimes that eventually comes back on you all on the health plan. So this notion of advanced primary care has been around for a long time. It kind of has a different name that everyone's kind of coalesced around calling it, this notion of advanced primary care. What it really is it's a really hyper-focused, personalized provider-patient relationship that's highly accessible by those members, both in person and virtually, and really wraps around this kind of integrated inside the offices, inside like our health centers and health centers with a lot of these cities and counties and governments all over the country and private employers. It wraps that around this kind of integrated care team with a bunch of services that we can do to really keep people engaged with us and with those centers without having to go outside and spend money in the open market. And so this notion of value-based care is really important because we're all taking kind of a capitated rate fee schedule to be able to treat those patients and everything they need to have done inside of our walls for basically a fixed price versus having that come back to you all in claims reimbursement that's going to continually tick up, meaning the more people utilize us, the more people that, or the higher the cost would be for that patient on all those services they might use, as you would see in the open market. Ours is capitated, kind of like a smorgasbord of everything you can eat for one capitated rate. And you see some of those services there that we would provide on the left and kind of below that really embody advanced primary care, not just us as a vendor, but the industry as a whole. You can go to the next slide there, Mark. So some of the key considerations that you have to think about in your shoes listening to this and what we've seen and kind of consulted with on the 180 plus kind of public sector entities that we work with. You kind of have a couple things here on the bullets. So employer objectives, like what are your objectives? And these differ whether you're a bank or financial services company to a certain extent versus a county government, right? Is it cost savings? Most of the time, yes, cost savings is a driver on some level for everybody, but is cost savings the primary driver, in which case we might look to engineer the staffing and solution a bit differently. Is it to attract and retain talent? Is it to reduce work injury, right? With public sector, you see police and fire, they have specialized needs and certain demands of the job that both require annual physicals and testing, but also physical therapy and things to keep them in their jobs productive and going forward. So those are different objectives that we've seen. The health center positioning, or I guess the type of model. I'll talk more about this on the next slide, but you're looking at, is it on site? Is it near site? Is it dedicated just to you and your members? Is it shared with other employers? We kind of have seen all those models work well, and they're all different. They all have kind of different pros and cons. I'll talk more about that later. Eligibility, who's eligible, right? Is it just the employees? Is it the employees and spouse and dependents, only on the plan or off the plan? Is it retirees? In order to really bend the cost curve and your total cost of care and what you pay on an annual basis for claims, some of the sickest people, costliest members tend to be those at home, not the employees, spouse and dependents. So how do we get them engaged with their health care and not just treat that for the employees who are out there on the job or at the office? Operating hours also is a big factor. The extended hours of operation, certainly in public sector roles, certainly with certain job responsibilities like police and fire and things like that, they are kind of 24/7 in many cases. So how do you have extended hours to support that workforce? The scope of care, advanced primary care really has kind of the full subset of primary care, acute urgent care, mental health. There's occupational health components, physical therapy is an option. We've kind of seen a lot of those built differently, just depending on the needs of the workforce. Then you get into things like the scope of services will drive the staffing. And then probably the big one that we see come up a lot is really around real estate. Real estate, the design, the construction, who owns it? Do we hold the lease? Do you hold the lease? Do you have space that we can build out? Is there something that we can make work? We really need around, I would say, around 2,000 to 3,000 square feet is what really we require for an on-site center. Is that kind of space available at any building or location that you might own that we can outfit and turn into a health center? And we have a whole team of people that help advise on that and do the consulting around the design and build and construction layout. Those are some of the key considerations. Really looking at this is like the access channels is really determining what the best access is for your population. These are kind of the models that we deliver, but these are models that we've seen delivered by a lot of different vendors in the space as well. Some better than others for sure, but I'll kind of start with the left to right. So the network, not to be confused with your health plan network, the network model is something that we call as a network, but really these are owned and operated by us or another vendor that are branded as ours, that are open to employers of all sizes in metro areas, right? So these are kind of the kind of things that we have in Richmond, Virginia that we just launched, Charlotte, North Carolina, Indianapolis, Indiana, Cincinnati, Columbus, Ohio, Denver, Colorado, throughout New Jersey. So we have probably 15 of these markets across the country where we've invested in that real estate. We own and operate it. We ensure capacity. It's only for employers who want to contract to buy in. Many cases, it's a mix of public sector, private sector kind of groups. Sometimes some union labor, Taft-Hartley kind of funds join in. But we manage that and own and operate that, which really lowers the overhead and the ownership that those groups need to take on building out that real estate, the capital expenses that come along with that, and holding leases and whatnot. A hub and spoke is kind of a blend of that model plus our traditional on-site, which we'll talk about in a minute. That's really where an employer would get together with other shared employers in that area to be able to share access to a center that they would kind of share in the build-out costs, share in the operating costs. Where we have those set up today, we allow employers to kind of add into those and buy into those in some cases, but a lot of times those have permissions based on who can utilize those. So if a city county government was going to build out one and open it to sharing, you would have first right of refusal on what kind of employers got in and when. Traditional on-site or dedicated near-site could also be lumped in here. Those are ones that are really built very specifically and designed for individual employer groups for their populations. They have total autonomy over the size, the scale, the scope of services. That's really just for them. It's really best for these large centralized workforces that really want to have that one site, and they're really taking on all the ownership and costs to be able to kind of offer that to their employee bases and their member base. And then on the right side, you have virtual. So virtual primary care is something that we've been doing since 2020. There's a lot of virtual providers. I would kind of differentiate this, underscore the difference between your traditional telemedicine, teledoc, MD Live kind of products, because those are great for their own reasons and use cases to be hyper accessible for really acute care. In our world, what we mean by virtual care, it's virtual primary care. We virtualize these centers to be available with our own employees that are able to have a persistent relationship. That's probably the key thing that differentiates that kind of model from traditional virtual care, where if Mark was my provider and I liked talking to Mark virtually, I could schedule with Mark every time I wanted to talk to Mark, the Dr. Mark, who was out there as a virtual provider, and be able to have that persistent relationship. He has my medical records. He'd be able to kind of pick up where we left off and have that virtualized relationship with him. In addition to this care team that's available as well, that has mental health coaching, chronic condition management, those kind of things wrapped around it. Those are kind of the channels to consider when you're looking at how you want to deliver access. And I think what we've seen most if you go back, Mark, real quick, what we've seen most of our own client experience, to draw on that, we kind of have these across the board. I would say most of those are doing traditional on-site or dedicated near-site just for them in certain markets, especially the smaller markets. The other side of that is we've seen a lot more gravitate towards this network model. Those are in markets that we have, like Richmond, Virginia, Charlotte, North Carolina, Indianapolis, Indiana are good examples of that, where we built out the infrastructure and have 5, 6 plus access points around the metro area. I know Mark's been actively working on that throughout New York, especially upstate New York, and some of those markets that are highly desirable, as we see there's opportunity from a cost containment standpoint with the current healthcare landscape. Sorry, take the next slide there, Mark. So looking at the patient experience and the complete kind of set of care. I mean, if this is done right by us or other vendors out there, and you're looking at doing something like this, the goal would really be to try to get 90% of the medical needs are met at these health centers. So providing that access to these kind of scope of services on that wheel on the right, you kind of look around there. More access to those services, both in person and virtual, is really where you're going to drive that high engagement. At the end of the day, it's about getting people engaged with their health, not just the healthy people, but getting the people that have risks, gaps in care, the disengaged on your health plans that are costing you the most, to get them to engage with us and kind of keep coming back and keep trying to solve some of those problems and address those population health needs that they have in the population, in your populations, to be able to get them engaged with that. So kind of care when you need it with same day and next day appointment availability, so hyper accessible. And then in particular for public sector entities, cities and county governments, we do a lot of expanded public safety services. So to engage police and fire in some of their unique needs. Sometimes those are the hardened workforce out there who put the capes on every day and rush out into danger and things like that, aren't the ones that think to take care of themselves as much, when they're off the shift. And so having this available to them to both get them in to be able to be compliant with some of those state requirements for annual physicals and the safety checks they have to do to be fit for duty, but also that's a good hook that we provide that to get them back in to really address some of those underlying challenges that they're still fit to do their job. It's not meant to prohibit them from doing that, but things they can work on to make sure that they are remaining healthy, addressing some of those chronic conditions, family history type things that we can, really personalize that care plan for them to keep them coming back. And so you'll see kind of on that wheel, really the host of things that we can do there, including the referrals, which Mark touched on, and the care navigation. All those things are kind of the standard kind of core set of offerings that we would provide in this advanced primary care model.
And Chad, I would just add here, if the audience, you put on your healthcare consumer hat and you look at this model, the typical experience is you go here for primary care, but then you're going to go over here to maybe get your labs done. You're going to go over here to get your prescription filled out. And then when you add, large geographic spaces, you're having employees having to take a full day off to go get care. The convenience that this model drives, having the care, the labs, the prescriptions, counseling, all these things in one space just delivers a level of convenience which lends itself to better adherence to the medical plan that we provide.
That's right. Here you'll see just kind of a little more detailed list. If the slide previously, it's kind of hard to see what's inside each one of those, but just to give you a flavor of sort of what kinds of things are included with each one of those buckets. And it is very comprehensive. And in many cases, a lot of these things can be delivered by a medical doctor or advanced practitioner, like a nurse practitioner that would be in a health center. But then some of these other things, condition management might need to involve a registered dietitian or a diabetic educator, or mental health delivered by a social worker, psychiatrist. Some of these things do have some specialized staff members that would be included here to provide that kind of much deeper level of care based on the needs of the population that can be included here for the needs of your population too. So that's kind of a view of all the what's in there. And then next question we get most commonly is sort of how do employer-sponsored health plans, right, or these centers, how are they paid? Where's the savings come from? The primary areas for where savings would come from. So how do you get to a flat, ongoing year-over-year increase or decrease? Well, it's coming from patient engagement. So kind of back to that value chain, get people engaged, give them a good experience to want to come back, targeted outcomes, that's where the savings come in. This is showing you kind of once you get that savings bucket, this is where the savings come from. So patient engagement, being highly accessible, keeping people engaged with that, the more that they are engaging with these health centers, that's capitated, already kind of paid for, the less that they're spending out in the open market. So redirection of that care to these centers for everything, including visits, but diagnostic tests, labs, getting their medications there, which is all subsidized or all very low cost or no cost to the member, gets them to come in, drive that engagement, and actually shifting spend that would otherwise happen in the open market, that if you added all that stuff up, to Mark's point, would cost a lot more to the health plan and to the member. So we do that in a fixed cost of care arrangement that provides all those things in there. There's sometimes some pass through of labs and medications as they're incurred, but those are significantly discounted at the cost we can buy them at. So it's 50, 60, 75% less than what it would cost at a local hospital, for example, for some of those same services. And then shifting those treatment settings from ERs, urgent care, and specialists into our walls. We use second opinion services. A lot of those doctors who will be leveraging that would keep people from going to specialist visits unless they really need to go to specialist visits. When they do need to go to specialist visits, we want to navigate them to the highest quality, most cost-effective options inside the health plan. So they're making very smart consumer buying decisions when they're going to do that, and they have all the facts in front of them, not just being kind of sucked up and sent into hospital system A or B without knowing the cost or quality. Reducing unnecessary services is another key, on the kind of going to the bottom row here, left to right. The reduction of unnecessary services that don't need to be done, that a lot of specialists and other provider offices might be inclined to refer out or have you do. our clinical teams and doctors aren't incentivized to do any of that stuff. So they actually have a higher incentive to make sure that we can avoid those things. So they're being very judicious in how much they want to refer out or what kind of tests they want to run. So it saves the patient money and you all health plan money. Population health management, kind of looking at the risk stratification. It's impossible to kind of point to all the like heart attacks that you might have avoided with a service like this and put a dollar amount on it. We know that happens, but we don't try to put a figure on it. But there are a number of ways you can quantify the different savings that are achieved through population health management and the success of those programs. So lowering someone's A1C level from a 13 or 14 down to a 7 or 8 has a value to the health plan that actuaries and health plans can put a value on, especially if that's going to reduce ER utilization or complications downstream for some of those chronic conditions. So there is a subset of these population health management related savings that we can achieve through this and kind of quantify in the data that we can track and show and work with the benefit consultants and the health plans to kind of point to that. And then all those kind of sum up to being this annual savings, really net of our expenses, as I said before. Many of our clients and the patients that are engaged see this kind of 25 to 30% reduction on a PMPY basis for people that are engaged with a service like this versus those that are not. And that's really kind of the sum of where all these savings kind of add up to come from, that eventually bend that cost curve for you all on your health plans in both private sector and public sector employers that we work with. One other kind of piece of advice, we in this value-based care arrangement, I know we put our fees at risk. So there was an element of having fees at risk against these kind of 4 categories, which are the key ones that we've talked about being part of that value chain. Any vendor that you would talk to, including us, should be putting fees at risk based on their performance. So it's us saying, we believe that we have a model that we've been doing now for 20 years that can drive and deliver the outcomes in these kind of pillars and show quantifiably that we will engage people, we will get them to re-engage, they will have positive outcomes that will translate into savings. So putting fees at risk against that criteria, I would recommend that to anybody who's looking at implementing a solution like this in the market today. So these are some of the book of business outcomes, just to kind of give you a flavor for what are the results and outcomes look like for Marathon Health. Now we're kind of talking really specifically about Marathon Health here. Our book of business as a whole, these are kind of the latest book of business numbers that we've pulled on a kind of annual, biannual basis that we've looked at. So really high patient satisfaction. That's back to that one of those first couple pillars: to get people engaged, give them a good experience so they want to come back. That's something that we really look to do, and repeatedly try to get people to re-engage and also kind of focus on net new engagement, which is where you'll see some of that come through with the data as well. 95% of patients rate us as excellent or good. These are things that we put performance guarantees against and track on a monthly, quarterly, annual basis with every employer that we work with. The one at the bottom with 59%, and really the one at the top right with 83%, that's really, those are the population health kind of metrics that we want to track and look for in outcomes. So 59% of patients are making progress against biometric risk factors that they have or that we've identified. And then 83% of the high-risk employees are engaging with us, right? Over the last 5 years in this case, all right? So our ability to really engage those people with the high risk, and then our ability to really make an impact to get them to reduce those risks, is something that we look at as really critical factors when it comes to population health management. An average patient who's engaged with us will have 3.5 visits a year. And then you'll see the book of business savings there from an ROI perspective is there is an ROI for this. It's usually, I would say conservatively, around 18 to 24 months, but we have many employers who achieve it in 12 months. So it's possible. And then being able to enjoy the benefits of that to compound over the next 3 to 5 years plus, as you have this in place, is where you start to get to the $2.75 to every dollar spent, 3, 4, 5 plus for every dollar spent. I believe the next slide starts to talk a bit more about our specific public sector outcomes and our book of business there. So we have about 180 plus public sector entities we work with today across the country. They actually have a very high patient satisfaction, member satisfaction, similar to our book of business at 98%. We tend to see that public sector groups have a higher ROI. So the last slide was 2.75 to $1 spent. Typically in our public sector groups, we tend to see higher than that, three to 1 on average over 3 years. Really great ability to get those high risk individuals engaged at 66%. And then our current panel of members that are eligible from public sector organizations that we work with is about 600,000 plus members that are members of cities and county governments and state governments that we work with today that utilize those services. You'll see some of the logos there on the side of some of those public sector groups that we work with today. And I think the last one we have here is just a quick case study that has Mecklenburg County, North Carolina on it. So Mecklenburg County has been a client since I want to say around 2018 with us. So that's Mecklenburg County is where Charlotte is in North Carolina. That's the county where Charlotte, North Carolina is in. They have a very distributed workforce there. Obviously, the city county government, police, fire, kind of everything you would expect with a city county government. We ended up implementing a solution there where they joined one of our networks out there. So we had 5 health centers at the time, and now we have 6 health centers there. We actually have a 7th health center that's owned by us that's just does public safety and occupational health. So they really are able to tap into 7 health centers that we have in that market. The importance of that was, them being able to drive the kind of engagement they have at 72% employee engagement annually, was really driven by the fact that a large county that really sprawls like a Mecklenburg County, one health center in the middle of town would not have probably attracted 72% of people to kind of drive from all kind of corners of the county in for care. So the fact that we had multiple centers as an engagement strategy that we've seen work really well with other cities and counties across the country, multiple access points, being able to cover a county that's very, very large. Don't have to fight traffic too much to get to an appointment. There's one kind of spread out all over town or all over the corners of the county to be able to access care really conveniently. In those centers, it's again the same kind of advanced primary care model with access to comprehensive primary care, behavioral health services, chronic condition management, wellness services. I believe there's physical therapy out there now as well. So Mecklenburg County is one of these great examples of a public sector group that we work with. We also work with the city of Charlotte as well, who both utilize this kind of network of sites that we've owned and operated there. And we've continued to add more capacity, more staff, more services over time as that's grown and the utilization increases. Kind of last slide here before we wrap up, and we're right on time at the 45 minutes, is a plug for, we feel so like public sector is probably our top, if not second, industry that we have as a client base. We have 680 plus clients, and you saw 180 of those are public sector groups. We've invested in actually a public sector practice leader. His name is Larry Morsey. He was a former client, former mayor of Rockford, Ohio, of ours, and ended up joining us after he left his time of being a mayor there, and really a great evangelist for this. What Larry is not a salesperson. We invest in Larry's time to really work with cities, counties, states, and other units of government that he could engage with to really be a thought leader for challenges that you all see in the public sector. He's someone who can come in and help talk about how to, he has his own experience with doing this at the city of Rockford, but also help make sure that there's some internal selling that needs to be done to get the right support from county commissioners and boards and the CFO and finance to make sure that this can be articulated in a way that everyone understands the value of what something like this can bring. This is not a trivial kind of purchase decision to be made, that it's an investment in the health and wellness of your populations and your employees and their families over the next 3 to 5+ years. There's a lot of moving parts there. He's got a lot of experience with that, especially with working with police and fire and some of the social determinants of health that are related to those jobs or those regions. Those are things that he's really passionate about. I would say he's a great resource to talk to just about this industry at large. If you're interested in hearing more about it and kind of wondering how this can be implemented, you can kind of draw upon all those clients that he has experience with in our book of business, at least, to kind of, help you through that process. And that is it.
I think we're on to questions to the Q&A.
Yeah, great presentation as always. I learn a little bit. I learn something new every time I hear this presentation. So first question is, how many employees do we need to have a health center to make sense, so that the health center makes sense. If we don't have enough employees, can we partner with another municipality or a community college that we work with or that's near the county center in order to create or build or contract with one of these health centers?
So I could take it, Chad, and feel free to weigh in.
Yep.
You know, the number of employees or lives, to think about it, so belly buttons, we use that are on the plan, depends. You know, in these networks, you know, where we have the Marathon owns the health center, we can have groups as few as, you know, 100 and 150 total lives come into these health centers. For more of the on-site partnership or near-site hub and spoke model, you know, I think initially you're going to want to have at least 950, 1,000 lives. I can tell you very specifically, you know, I've got a group I work with here in Maryland, Queen Anne's County and Queen Anne's County Public Schools. They came together to be kind of that hub and spoke model. So they banded their numbers together to spread out that initial cost. And now they are allowing other local employers to come in, like the community college. There's another employer right down the road from them who'd like to join as well. But typically, just to get started kind of with a hub or a on-site near-site, really want to try to hit that, you know, 1,000 total lives number. Chad, anything to add there?
No, I think you're spot on. It's around 1,000 plus, and usually we see in the public sector space, especially, we see cities, counties, schools, transportation, library, other kind of offshoots of public sector groups that are there in the same area. The reason why we find those groups tend to gravitate towards each other to kind of get the right number of lives they need to kind of share in the costs is because all your populations tend to be very local, very regional in nature, and similar type of workforce, similar kind of makeup, pay scale wise. People live and work all over that kind of county metro region. So yeah, those are the logical places to really look.
And if, you know, the groups are adjacent, you know, part of the process is doing some mapping through we call it a geo mapping, geocensus. That allows us to map a population to an area of highest density. They, you know, shoot for 80 to 85% within a 15-mile range. When you're basing it off where people live, you know, you can really create a centralized positioning of a health center. So that's another part of kind of how we can take multiple groups together, include them in one analysis, and spread out the cost between all the lives.
Great. Does this model make more sense for self-funded employers, fully insured employers, or both, or a combination?
I would say the vast majority are fully insured, and that is a result. I'm sorry. Yes, I'm sorry. Self-funded. Yes.
There you go.
Are self-funded, and that is a product of, you know, us being able to show hard claim savings for self-funded employers. We do have fully insured groups. You know, the majority of those that we have, they're offering it as you know, a benefit to really attract, retain, you know, provide access to their folks. But it's really on the self-funded side where we can show hard claim savings and cost of care reduction.
So for those entities, these employers that have moved in this direction, how has it impacted or integrated with their current health plan? Does it impact the cost of their health plan or the way they interact with their current health plan?
So they're still going to have their health plan, and whether you say it sits adjacent to, in front of, what have you, they're still going to have that plan. As you saw earlier in the presentation, we can take care of about 90% of what folks' needs are. So we're really only referring out the 10%. But if somebody breaks their arm, needs surgery, somebody gets cancer, you know, they're going to need higher levels of care. So they will still have their standard kind of insurance. From an integration standpoint, as part of our setup and implementation process, we will set up to send $0 claims over to the carrier. That allows the carrier and the employer to see kind of what's being done in the health center through a total reporting package. So it's all kind of the encounter codes. And then we're also receiving data from the carrier, medical and RX. That's, as what Chad was saying earlier, on a population health perspective, that's what allows us to pull in data, see what type of care folks are getting, gaps in care, et cetera. We're also plugged into the local health information exchanges. So if one of our patients shows up in the local emergency room, that pings us, and we're able to do follow-up with that patient as well. So we do integrate with the health plans. That's a big part of our initial setup process. And of course, we've got, do that with many plans and carriers across the country.
Yeah.
Do you have to have?
Just to underscore that. All right, go ahead.
Go ahead, Chad.
Next question.
Go ahead.
That's fine.
Do you have to have the primary care services, or can you just have urgent care and occupational health services?
So we obviously believe in primary care, holistic care. However, we have many clients that partner with us specifically just for urgent care, acute care, plus occupational medicine. So that kind of goes back to the philosophy of meeting the employer's needs and what their objectives are. So, I can speak for Marathon. We are flexible in terms of our delivery model. We have clients that have primary care, urgent care, just urgent care, occupational medicine, et cetera. It's all based on what the employer's goals and objectives are.
Do you have any experience, and how can you respond to how it works with workers' compensation plans? A number of our counties run their own workers' comp pools. How does this integrate with workers' compensation?
Sure. So kind of at the base level, we can do kind of just kind of standard occupational health things like pre-employment drug screenings, fitness for duty. Again, speaking just from a Marathon perspective, we do have a full build out of occupational health services, which includes workers' comp, return to work, fitness for duty, surveillance monitoring, et cetera. So that again becomes a specific offering that we're able to partner with employers on, and really if they want us to take more of that on for them, and kind of consolidate the number of providers or services they're working with, we can certainly take that on their behalf or collaborate with their workers' comp plan or provider.
Does Marathon work with the providers that are already in the community, or are you recruiting providers to work in these health centers?
So we are recruiting providers to come in and work in these health centers. We have a full recruiting team and a medical recruiting team that goes out and finds the providers. A big question we get is, well, Mark, you've spent so much time talking about a primary care shortage. What's your key to success? How does Marathon attract? The answer to that is, if you think about it, essentially we're handing a provider a practice without any of the investment risk for them to start it up. We're allowing them to get back into medicine for the reason that they got into it, spend more time with patients, have an impact on health. And then lastly, we're not doing any insurance, claims, we're not submitting claims. So our providers are not having to spend nights and weekends charting and coding. So there really is a work-life balance that we're able to bring to the table for our providers. So we will actually go out, recruit them, make sure that they have all the experience necessary from a medical perspective. We do allow our clients to interview, meet with the providers to make sure, more so to make sure that it's a fit from a culture perspective. But yes, we're directly going out into the community or the adjacent communities and finding providers to join us.
How are the fees structured? Is everything included, or are there certain pieces that are passed through?
So of all those things that you saw on the wheel, that's considered our core services. Those are all included in that per member per month fee, except for we pass through so we typically stock around 150 to 200 generic drugs, both acute and maintenance medications in the health center. So we pass through any drugs, labs, or vaccinations directly to the client at our cost as utilized. So if you think about a monthly invoice, you'd see your flat per member per month fee, and then we would pass through drugs, labs, vaccinations as utilized.
So for employees that already have a primary care provider, do they have to use the health center, or can they stick with their current primary care provider?
Great question. So the answer to that is no, they do not have to use the health center, although we're going to work very diligently with the employer to drive as much care as possible. Listen, we believe in primary care. We think it creates better outcomes. So the folks that do have that relationship, of course, we encourage them to continue that relationship. What we find, though, is folks will supplement their care through the health centers. For example, if they have an urgent care kind of issue of a sore throat, and it's going to be easier because they can get in same day, next day, we tend to see them come to our health centers. Same with labs, things like that. Now, folks that have chronic conditions like diabetes, they can come to our health centers, get their A1C tested, and with the proper protocol, privacy, paperwork, et cetera, we can share information with that patient's primary care provider. So no, they do not have to use Marathon as their primary care or declare it as their primary care, but they can use it as a supplemental resource.
I have one more question in the queue
Sure.
here. I want to thank you and thank everybody for attending and sticking on for this hour, and thank Marathon and Marathon Health and Chad and Mark for their presentation. Do you currently have locations in the state of New York, and where would those be?
So we do have locations. They are more of those client partnerships, so they're not open to other employers entering. But we've got a couple in New York City. We've got one up in Liverpool, and then we've got one out in Erie with different types of employers, a couple of manufacturers, and then a couple, interestingly enough, law firms as well. But obviously, we see tremendous opportunity with public sector and specifically, county employers. We think this model fits very nicely. So to echo Mark's statements on behalf of Chad, thank you all so much for the opportunity to be here, provide some education awareness, and we're here to have further discussions if you're interested.
Thank you both for your time today. We appreciate it. We appreciate the partnership.
Thank you.
Absolutely. Thank you all.
No problem. Bye-bye.